Good day, Miss Mary Grace Obdulia Amok, RN. My name is Joshua Go from Bachelor of Science Level 4 in Nursing, Section A. So I am here going to demonstrate the intravenous fluid therapy or the IV therapy. It is an insertion of the needle or the catheter that we call into the vein of a patient on the depending on the written order of the physician, like for his or her prescription. Essential when the clients are unable to take the fluids orally or unable to take the fluids orally. It is an efficient and effective method of supplying fluids directly into the intravascular fluid compartment and replacing the electrolytes of the patient or if there's a losses. So there are three purposes of this procedure. Number one is maintenance. So for the maintenance therapy, it provides all the nutrients necessary to meet daily patient requirements to replace the insensible loss which can occur the perspiration from the skin and some moisture from respiration. And then we have the replacement therapy. Replacement therapy is necessary to meet the fluid, electrolyte, or blood product deficit of the patient in acute distress and is supplied within 48 hours. And then we have the restoration therapy. Restoration therapy is the reconstruction of fluid and electrolyte needs on a continuing basis until homeostasis returns. The materials that are needed in this procedure are: number one is IV tray with IV solution, administration set, IV cannula, forceps soaks with antiseptic solution, alcohol swab or cotton balls with 70% of alcohol, IV pole, you have sterile 2x2 gauze, plaster, tourniquet, clean gloves, and a splint. So as a nurse, following the basic guidelines of the nursing process: assessment, planning, implementation, evaluation, and documentation. For the assessment, we're going to assess to determine the doctor's order, and then vital signs like skin turgor, allergy to the tape, or there's a bleeding tendency. We're going to check for disease or injury to the extremities, the status of the veins, determine whether it is appropriate for venipuncture site. And then we have the planning. Our planning is to review the client record regarding desired solutions, rate flow, and previous venipuncture and history of allergy. Note also for any difficulties and complications encountered and how they were managed. And then for the procedure, it is how it is done. So in setting up, verify written prescription and make a level, explain the procedure to the patient, perform hand hygiene before and after the procedure, equipment preparation, check the sterility and integrity of the solution, IV set and other devices. By labeling, place the IV label on IVF bottle duly signed by the RN who prepared it, by patient's room, number, solution, drug incorporation, bottle sequence and duration, time and date. And then open the seal of the IV infusion aseptically. Observe aseptic technique. Disinfect the rubber port with cotton ball. Wet with alcohol. Open the IV administration set. Close the roller clamp and spike on the infusate. Fill drip chamber to at least half and prime it with IV fluid aseptically. Expel air bubbles if any and put back the cover to the distal end and the IV set. Hang the solution container on the pole. Adjust the pole so that the container is suspended about 3 feet above the patient's head. And then prepare the IV needle and catheter tape. Hang the pieces of tape from the edge of the table. Site selection: assess the patient's vein close to appropriate site. Location, the size, the condition. To start the best, lowest vein, a soft straight is the ideal choice for venipuncture. Dilate the vein. To dilate the vein, place the extremity in an independent position lower than the client's heart. Apply the tourniquet 5 to 12 cm above the injection site depending on the condition of the patient. Explain that the tourniquet will feel tight. If the vein is not fully sufficiently dilated, massage or stroke the vein distal to the site and in the direction of the venous flow towards the heart. Encourage the client to clench and unclench the fist. Lightly tap the vein with your fingertips. And then gloving and site preparation. Gloves must be worn. Clean the site with cotton ball. By wetting the alcohol, use the circular motion, working from the center outward to a diameter that should be allowed to air dry. Another thing is in cannulation. In cannulation, use the non-dominant hand to pull the skin taut below the entry of the site. So this is the vein that we're going to do. We see the sides of the vein of the arm, the cephalic, the ancubital fossa, cephalic, and basilic vein. We have the mucosal and the digital vein. Okay. And then we have the other picture, and then holding over the needle with the catheter at 15 to 30 degree angle with bevel up. So this is how I show you. This is the first major types of vein. So this is how it is done. Okay, and then insert the catheter through the skin and into the vein in one thrust. Sudden lack of the resistance is felt as the needle enters the vein. And then once the blood appears in the lumen of the needle, or you may feel the lack of resistance, reduce the angle of the catheter until it almost parallel with the skin, and advance the needle and the catheter approximately by 0.5 to 1 centimeters. Further holding the needle, position steady, advance the catheter until the hub is at the venipuncture site. The exact technique depends on the type of catheter it's used. Release now the tourniquet. After that, remove the protective cap from the distal end of the tubing and hold it ready to attach to the catheter. Carefully remove the needle, engage the needle safety device, and attach the end of the infusion tubing to the catheter hub. And then to inflate the infusion, tape the catheter by using the U method. So what is this U method? The U method is place one strip sticky side up under the catheter hub. So fold each end over so that the sticky sides are against the skin. And then you can place that the second strip sticky down over the catheter hub. Place the third strip sticky down or tubing hub. So as what is shown in the video or the hands of the patient. Then you can now dress the venipuncture site with a small amount of antiseptic ointment. Then goes the square. Okay. Remove soiled gloves and discard appropriately. Loop the tubing and secure it with the tape. Regulate the flow rate of the solution according to the order of the doctor, according to the chart. And then make sure to relevant all the data that you've gathered. So in changing the IV bottle, it is easy. If you want to change the IV bottle, just follow the procedure of setting up from procedure 1 to 11 and then procedure 21 to 22. So now I'm taping the hand of my patient so that it won't be removed while the patient is moving. So this is how it is done. We have now the monitoring on the intravenous infusion. In monitoring, assessment includes the operation of the infusion site, potency of the system, and then type of fluid being used at the rate flow to response of the patient. Review all appropriate materials and confirming the type of tubing, the controller, and the pump being used. And being infused. So observe the flow rate, inspect the patency of the tubing and the needle, and then make sure to inspect the insertion site for fluid infiltration. If an infiltration is present, you can stop the infusion and remove the catheter by applying a warm water or a warm compress to the site of the infiltration. Then restart the infusion at the other site. And then infiltration is not evident but the infusion is not flowing, determine whether the needle is dislodged from the vein. Gently pinch the tubing adjacent to the needle site and use a sterile syringe of saline to withdraw the fluid from the port near the venipuncture site. If the blood does not return, discontinue the intravenous solution. Inspect the insertion site and symptoms for inflammation. Inspect and palpate the site at least every 8 hours. If phlebitis is detected, discontinue the infusion and apply warm compress to the infusion site. Teachings to be imparted: instruct the client to avoid sudden twisting or turning movements of the arm with the needle or catheter. Avoid stretching or placing tension on the tubing and try to keep the tubing from dangling below the level of the needle. And document all relevant information of what you have found. Then we have the discontinuing and intravenous fusion. Assessment includes appearance of the infusion site, any bleeding from the infusion site, amount of the being fluid infused, appearance on an IV catheter. Then review the physician's order, assess and inform the patient of the discontinuation of IV infusion, prepare the equipment such as the clean gloves or dry aseptic soak swab and small dressing or tape. Wash your hands before and after the procedure, and then clamp the infusion tubing. Moisten adhesive tapes around the IV catheter with antiseptic. Soak the cotton with soaked cotton. Loosen the tape at the venipuncture site while holding the needle firmly and applying incanter section to the skin. Don clean gloves and hold sterile gauze above venipuncture site. Withdraw the needle or catheter from the vein. Pull out the catheter in the line of the vein immediately. Apply firm pressure to the site for 2 to 3 minutes. Examine the catheter removed from the client. Cover the venipuncture site. Apply sterile dressing and then document all relevant information. And then for our evaluation, we're going to evaluate the client's response, tolerance and reaction to the procedure, and then observe for the insertion and the site for redness, coldness, or swelling in the patency of the IV insertion. Evaluate the effectiveness also of the procedure. And then also for the documentation, we're going to record the start of the infusion and the client's chart, include the date, the time, and the venipuncture, amount of type of solution used, including any administrative container, number of flow rate, the type, the gauge, the needle used, the catheter, the venipuncture site, and the client's general response. And then another procedure that we're going to do is initiating, maintaining, and terminating a blood transfusion. Blood transfusion, it is the introduction of a whole blood or components into the venous circulation such as plasma or whatever, and including the blood. So it increases the client's, the purpose of this is increases the client's hemoglobin and hematocrit to improve circulation and oxygen distribution. The same thing, following the basic guidelines of the nursing process. For the assessment, we're going to determine if the patient knows the reason for the transfusion, as the client is had transfusion reaction in the past if he or she had before, and then assess the vital signs for our baseline data, including BP, pulse. We are going to check for the respiratory, the depth, and then the temperature, determine to allergies and adverse reactions to the blood. And then for our planning, we're going to plan to review the client record regarding the desired blood product, the flow rate of the flow, the previous venipuncture and history of the client, and allergy, note any difficulties and the implications encountered and how they were managed. For the implementation, this is how it is done. Verify the client consent and obtain baseline data before the transfusion. Make sure also to establish intravenous line. Check whether the needle is appropriate to administer blood, 20, make sure 20 or larger. If the client does not have an IV solution infusing, start an IV infusion of a normal saline solution. Explain to the client what you are going to do, why it is necessary, and how he or she can cooperate. Explain the reason for the transfusion. Make sure you instruct the client to report promptly any sudden chills, nausea, itching, rashes, dyspnea, back pain, or any other unusual symptoms. Provide for a client privacy and prepare the client. Check for correct identification information. Check the client's identification band. Do not administer blood to a client without an armband. Observe the 10 RS when preparing and administering blood transfusion. When blood arrives, check the blood and client information with a second nurse. Compare the blood package with order slip, checking client's name, hospital number, blood type, expiration date. Client's name band, name and hospital number on the name band, and if typing the cross-matching were done. Complete bank slip the date and time of transfusion initiation and nurse checking information. And nurse checking, check the record pulse, respiration, BP, and temperature. Wash hands and observe appropriate infection control procedures. Prepare the infusion equipment. Prepare blood bag. Don gloves. Insert piercing pin into the port of the blood bag. Fill the drip chamber at least half full. Hang the bag. Prime tubing. Remove air bubbles. Disinfect the Y port of IV tubing and insert the needle pole from BT administration set and secure with adhesive tape. Close the roller clamp of an IV fluid of plain NSS inside of tubing and open regulator of blood inside the tubing and transfuse the blood via injection port and regulate 10 to 15 GTTS. Initially for 15 minutes and then the prescribed rate. Most reaction occur within first 15 minutes. Observe the client closely for the first 15 minutes. Of note adverse reactions such as chilling, nausea, vomiting, skin rash, or tachycardia. Check VS and temperature again 15 minutes after beginning of the transfusion, then every half hour hourly until transfusion is complete. Check the completion of the delivery of each unit of the blood. Swirl the bag to mix solid with the plasma. And then make sure also to, when the blood transfusion is completed, close the roller clamp of the BT, regulate the IV of plain NSS, remove an empty bag, recap the spike. Discard the blood bag and BT set and sharps during and after transfusion. Monitor the client closely for signs of transfusion reaction. And then after that, make sure the last procedure is you record the completion of the transfusion, including vital signs, type of blood and unit number, sequence number, site of the venipuncture, the size of the needle that you are going to use, make sure size 20 or larger, 23, and of course the rate or the drip rate. And then for our evaluation, we're going to evaluate the client's tolerance and reaction to the procedure. Evaluate also the fluid overload and the client closely for signs of transfusion reaction, and then evaluate for the effectiveness of your therapy. And then for the documentation, make sure we record completion of the transfusion, including the VS, the blood type of the patient, the unit number, the sequence number, the site of the puncture, and the needle and the drip rate. So that's will be all for our intravenous therapy.